Welcome everyone, and thank you so much for coming to this sponsored presentation by ZEISS entitled Advancing Retinal Diagnostics with ZEISS Forum Retinal Workplace. I'm Dr. Carolyn Majcher, professor and the director of residency programs at the Oklahoma College of Optometry. And we'll just go ahead and dive right in. So I've prepared some cases that I think really are going to help highlight how we can use ZEISS Forum review software, their technology packages, and AI software in order to really leverage the best patient care possible for our patients. So this first case is a 39-year-old male. He was coming in for a 2-month follow-up following central serous chorioretinopathy reactivation following a steroid injection for some shoulder arthritis. And as we can see, 2 months ago on his OCT, he had some subretinal fluid. His vision coming in at this follow-up and on the initial presentation as well was quite good, 20/20. So here in ZEISS Forum Retinal Workplace, we're actually able to overlay that 21-line raster OCT scan on top of the color fundus photography. And we can see he has a multi-lobed serous pigment epithelial detachment. And on this follow-up, fortunately, he has no subretinal fluid. It has resolved compared to his initial 2-month examination. He does have some RPE atrophy and choroidal hypertransmission that we can appreciate. And it's really nice that we can correlate that with our color fundus photography and some of those RPE abnormalities that we see on our clinical examination. Also note, and we see really nice imaging down here with these raster scans of the bottom of the choroid, so we can appreciate how thick this choroid is consistent with pachychoroid and central serous chorioretinopathy disease. Looking at the ZEISS Forum Retinal Workplace Macular Thickness Analysis now, that's going to allow us to compare and synchronize 2 or 3 even macular OCT cube scans. And the OCT scan on the left is from 2 months ago when he had this pocket of subretinal fluid. And today, on this particular examination for follow-up, we can see that that fluid has now resolved. So it's really nice that we're able to view these scans side by side, scroll through them to really confirm that there's been improvement in the subretinal fluid and resolution in his central serous chorioretinopathy. But the reason I really wanted to show you guys this case is to highlight what was hidden behind the clinical examination in his left eye that we were able to pick up with OCT angiography imaging. And so here in his left eye on the Claris color fundus photography, we can see he has some macular pigment modeling that's highlighted even more so on fundus autofluorescence. And then in the ZEISS Forum Retinal Workplace, we're overlaying again that 21-line raster scan on top of the color fundus photography images so that we're able to correlate those OCT abnormalities to what we're actually seeing clinically. And in the area here of the RPE modeling, we can see that there is this shallow irregular RPE elevation, or some people call this like a double layer sign. And when we have that separation of the RPE up off of Bruch's membrane, we have to suspect that there could potentially be a sub-RPE or type 1 choroidal neovascular membrane present. So of course, we're going to go on and do OCT angiography imaging. And for this particular patient, I'm going to choose a 3-millimeter scan in order to maximize the resolution that I can get right in the area of that shallow irregular PED. So here in ZEISS Forum, I'm able to access my angiography data right here. I'd go ahead and double click on that. And then I'm able to view all the different preset NFOS displays and click on them and view the angio and the structure side by side, as well as the B-scan overlay. And so what we can see is that this patient actually has a well-formed neovascular net that we had suspected just based on the structural OCT presentation. Because this doesn't have any fluid or any blood or hemorrhage associated with it, there's no treatment that's required, but it's certainly something that we're going to monitor more closely. And should his central serous reactivate, it may be something that be more appropriate to treat, say, with anti-VEGF agents, as opposed to, say, like macular photocoagulation. Let's now move on to our next case, which is a 68-year-old male. He's coming in for a routine examination. He does have a history of dry macular degeneration with slightly reduced vision here in the left eye of 20/40. We can see on his clinical examination, he has some drusen and pigmentary abnormalities and non-central geographic atrophy. And his OCT shows a very similar finding to our first patient, this shallow, irregular pigment epithelial detachment, but without any fluid and without any hemorrhage on our clinical examination. We're always going to suspect in a situation like this, based on the structure alone, that there could be a neovascular net located in that sub-RPE space. And lo and behold, our OCT angiography shows us very nicely this well-formed neovascular net. And on our B-scan overlay, we can see that this pigment epithelial detachment is highly vascularized and red. We asked this patient that has a now non-exudative choroidal neovascular membrane, meaning there's no fluid, there's no hemorrhage, there's just this neovascular net present. We're going to monitor him very closely because we know that there's a greater risk of conversion to exudative disease. And so I asked him to return in 3 months. However, he actually returned 6 months later, not because he was having any problems. His visual acuity was stable. He wasn't having any metamorphopsia or complaints. But we can see now on his clinical examination here in ZEISS Forum that he has some exudation on his Claris photography. He also has some subretinal hemorrhage associated with that. So I'm able, again, to overlay my OCT and my color fundus photographs here. So I'm able to scroll through in real time to see what's going on now from an OCT level. And of course, I want to compare my baseline examination to this now 6-month follow-up. And I'm able to actually synchronize and register those two 21-line raster OCT scans. So here we can see in the exact same location, and I know that with certainty, where there wasn't fluid before, there is now some subretinal fluid suggestive of conversion to exudative AMD. So this patient must now definitely, be referred to a retina specialist for anti-VEGF therapy. In looking at the ZEISS Forum Retina Workplace Macular Thickness Analysis, again, this now allows me to compare and synchronize and scroll through 3 macular cube OCT scans and view the corresponding quantitative trend data. And in this case, we can see this patient goes from having a regular flat RPE contour on his baseline examination to then having this shallow irregular pigment detachment and then forming exudation features, so subretinal fluid as well as intraretinal fluid. And it's this exudative conversion that is really prompting and important we recognize and then refer that patient to a retina specialist for anti-VEGF therapy. A feature I love about ZEISS Forum Retina Workplace is how customizable it is. So I can alter the data being displayed in this trend line analysis depending on the exact location of the pathology. So in this case, I want to track the central subfield thickness in orange, but then I also want to track that nasal inner ring because that's where that pigment epithelial detachment was located, and where that neovascular net was also located in the PED. So it's very important, and I think really valuable that we can track the quantitative data in the exact location of the macular region that we want to in order to monitor improvement with anti-VEGF therapy over time. Next case is a 70-year-old male. He has a history of high-risk intermediate stage non-exudative macular degeneration, because he has some large drusen and pigmentary changes on clinical examination. Entering best-corrected visual acuity here was 2020. I want to point out some high-risk OCT features on his baseline OCT. So we have some large-sized drusen with intraretinal hyperreflective foci. We have loss of the ellipsoid zone of the photoreceptors, numerous reticular pseudodrusen, these hyperreflective nodules in the subretinal space. And then we have an area of impending geographic atrophy, where we have loss of the photoreceptors and the RPE and some early choroidal hypertransmission. So as we follow this patient's journey over the next 3 years of follow-up, ZEISS Forum Retina Workplace is going to provide us with many tools in order to monitor progression of this patient's atrophic AMD over time. And we're going to access most of those tools in the Advanced RPE Analysis tab. So here I'm selecting the sub-RPE slab from these various icon options. And within this sub-RPE slab, It's basically generating like an in-phos OCT image just under the RPE surface. So imagine rather than taking our like conventional cross-sectional B scan, we're taking a cut under the RPE surface, and what we're highlighting are areas of choroidal hypertransmission, or bright areas that would correspond to areas of geographic atrophy. So basically what we're generating on these NFOS scans here are a 2D map of choroidal hypertransmission in geographic atrophy area. So our trend line analysis down here is also really valuable. So not only do we automatically delineate areas of geographic atrophy in this analysis, it then quantitatively tells us what is the area of geographic atrophy that's changing over time. And in this patient, we can see it's getting larger as he goes on to develop more areas and enlarging areas of geographic atrophy. We can also see that it's getting closer to the center of the fovea, which is depicted by this orange line here. So as the orange line is going down, it's getting closer and closer and closer and threatening his central vision. So a great way for us to monitor his geographic atrophy using this sub-RPE slab. Within ZEISS Retinal Workplace, we can also superimpose and register OCT raster scans and color fundus photography on top of what we're viewing in this workplace. So this really allows us to ensure that the delineation of these geographic atrophy areas has been accurate and allows us to correlate our OCT and clinical pathologic findings. And what I really like too is the addition of these higher resolution raster scans is going to allow us to detect some of these earliest areas of geographic atrophy possible, so we can make sure we refer these patients promptly for therapy. Near-infrared reflectance imaging is another great way to monitor geographic atrophy progression, in addition to that sub-RPE slab that I showed you guys. And we can also visualize these serial near-infrared reflectance images across in ZEISS Forum very nicely in this retinal workplace. Here's another patient, so a different example, but I just wanted to highlight the utility again in ZEISS Forum, how we can visualize these near-infrared reflectance images over time in order to help us track progression of geographic atrophy. This next case is a 60-year-old female who also has a history of high-risk intermediate stage macular degeneration with large coalesced soft drusen in the maculas of both eyes. Her vision was slightly reduced around like 20/30 or so on initial presentation. We can see she has large soft drusen, almost like to the point of drusenoid PEDs bilaterally. And then over the course of about 5.5 years, we're seeing this drusen, this is the left eye down at the bottom, the right eye at the top across time, that area of large drusen regressing and disappearing, and unfortunately forming center-involved geographic atrophy in both eyes. So in the Advanced RPE Analysis tab, we're able to access an RPE elevation map. And that's going to allow us to track the regression of drusen in this patient's right eye here that I've displayed for you. And in this map, warm colors represent areas of RPE elevation. And so as this sort of large area of coalesced soft drusen collapses, that should be a signal to us as we're looking across these maps. That's a high risk factor for progression to advanced stage macular degeneration. And in this particular case, unfortunately, central geographic atrophy. So we said a good way to identify and track geographic atrophy progression over time is utilizing that sub-RPE slab. And we can see on that sub-RPE slab how she starts to develop geographic atrophy and then how it invades the center of the fovea at the final follow-up. And just another example of the utility of using the sub-RPE slab in order to monitor progression of geographic atrophy and why you have to use these multimodal imaging technologies to complement your clinical exam. If we're just looking clinically at this patient, it's hard to tell if the geographic atrophy is progressing because the contrast between the GA lesion and the surrounding retina isn't that great. But when we utilize our technology available to us in ZEISS Forum Retinal Workplace, and the sub-RPE slab, we can easily now monitor this patient's progression. This is a 6-year time frame. We can see how the geographic atrophy has really encompassed nearly the entire aspect of the fovea macular region by the end of the 6-year follow-up period. Our next case is a patient with very high myopia, approximately 14 diopters in each eye, with mildly reduced best-corrected visual acuities of 20/30 and 20/40. And we can see on her ultra-wide field Claris color fundus photography, she's had some past barrier laser treatment done for like some retinal breaks. And what else I love about the Claris imaging technology is that even though it's wide field, we get this nice peripheral imaging, I'm still able to magnify in and zoom in the macular region in order to detect subtle changes in the posterior pole. So we can see there's areas of hypopigmentation, potentially some lacquer cracks here in both eyes. Here in the Forum Retinal Workplace, I've now superimposed and registered those OCT raster scans on top of my color fundus photography. We can see the areas of hypopigmentation correspond to areas of choroidal hypertransmission and some RPE thinning. Of note, she also has myopic tractional maculopathy, where in the foveal region, there's almost like an inner retinal schisis with an overlying epiretinal membrane and a very thin choroid of note in this particular patient. The macular thickness analysis will allow us now to track progression in this patient over time, which is critical for us as optometrists to know, is this a patient I refer or not? If the OCT remains stable, the best corrected acuity remains stable, this is a patient I can feel confident about keeping in-house and just monitoring on a close basis, as opposed to referring this back out to Retina for consideration of surgery. So in our macular thickness analysis workplace here, I'm able again to customize what I want to visualize on these particular trend lines. And so for this patient, I'm just looking at the average cube thickness as well as the central subfield thickness here in orange. What else is nice, if you want to see a particular value on a specific visit date, you can just click on that region and say, oh, the average cube thickness was this exact value on that particular day or that examination. And as I had mentioned earlier, once we register all of these cube scans together, we can scroll through them in synchrony, which again just really confirms for me that this patient has been stable over the course of the past 3 years. And so this is something that I feel comfortable monitoring in my own practice because I have the tools and technology to ensure that things aren't getting worse over time. And this last case is a 22-year-old female who was referred to me from the contact lens clinic because she was found to have extensive lattice with holes. Again, a high myope, about 5 diopters, give or take. She was asymptomatic in vision of 20/20. This is her left eye. We can see on the ultra-wide field Claris fundus photography, she has extensive lattice with hole formation. But in the right eye, she had an area of lattice with an atrophic hole and then a bolus elevation of the retina beside it. And so the concern is, could this potentially be a rhegmatogenous retinal detachment that's starting to form? So here I've taken an off-axis OCT raster scan. I'm able to register and overlay that on top of my color fundus photography. So you can see I'm in this region, and I can be certain I'm in the region of that bolus retina elevation. And we can see there's subretinal fluid with a retinal detachment. So this patient has a rhegmatogenous retinal detachment secondary to an atrophic hole in lattice, which is quite rare, but it isn't rare if it's in your chair. So this is a superior detachment, certainly a urgency in order to get this to Retina and get this surgically managed. We got her surgery the next day. So she ended up getting a scleral buckle with retinopexy. And we can see her scarring here. And then this is the actual buckle on her final follow-up with us, utilizing the Claris ultra wide field color fundus photography imaging. I want to thank you for your time and attention, and please feel free to reach out to me with any questions about these cases.